Looking forward now, joining us now, the director of the Center for Infectious Disease Research and Policy and a professor in the medical school at the University of Minnesota, Dr. Michael Osterholm. Doctor, thank you for being on. I'd like to ask first about testing. At the rate we're going, without it coming from the government, sort of streamlining and using perhaps the DPA to get a national, uniform, robust mass testing effort, it seems like we're in a kind of a convoluted space where there's some types of testing here, other types of testing there, and then in many cases across the country, non-existent testing. At the rate we're going, without it coming from the government, when are we going to have enough testing that's uniform enough that we can map out this virus and protect ourselves?
Well, first of all, let me just say that testing has almost become the kind of what you call mantra that we saw post 9/11, where Cipro is everything, testing is everything. And I want to be a little cautious about that. I think we've gotten far too ahead of ourselves on the testing issue, what it can and can't do. First of all, we have a major shortage of testing, in large part because of the reagents, the chemicals that we need to run the test. In December of this past year, testing was done routinely around the world for the kind of tests that we did. And then Wuhan happened, and the need for reagents was boosted substantially. Then when the world caught on fire, instead of filling the reagent pool with a garden hose, we needed a canal full to fill it, and it hasn't happened. So people who go around promising we can deal with this by testing just don't understand the fact that it's going to take us months, even under the most vigorous of efforts, to get the kind of manufacturing for these reagents. The second thing is these testing situations yield a lot of problems. We now know today, for example, the FDA has really, I think, done itself a disservice by, when we didn't have enough testing, basically opened it up so almost anybody could now be approved for testing. It's kind of like the Wild West.
Right.
By their own admission last week, they admitted that of the testing, that for the blood testing, of the 70 tests that just got approved, 35 were junk. That's their own words. So I think we have to talk about testing in all of its forms.
Well, that's why I'm asking, because nobody can get an answer on when we can catch up with a country that was able to use testing to get on top of this. Are we ever going to get there? Because, like I said, it's jumbled, it's convoluted. There are different entities making different types of tests. This seems really disorganized, and you were saying months. It sounds to me like many months.
Well, it is. And Mika, you're right on the mark with this. We've been calling for some time. We need a major national presence to help provide the leadership. And while we need the private sector to be there, basically, we've also got to say, don't promise us. I last week was in a debate with a world-renowned economist, a Nobel Prize laureate, who said we need to test 30 million people a week. And I said, you can't. And he looked at me like I just didn't want to. We can't. So I think you're right. We're a long ways off. But let me add one other thing. People who thought that testing was the answer in Asia, for example, Singapore, Japan, Korea, Hong Kong, are all having problems right now, even though they have testing in place. And they're losing control of what's going on over there. So I just want to add a word of caution to say, before everybody jumps too far on the bandwagon, let's understand what testing can and can't do. It's important. We need it, and we don't have it, but it's also not going to be the savior that many people put out there that it will be.
All right, so let's talk, Dr. Jessica, over here. Let's talk about moving forward. We can talk about the mistakes the CDC made. We can talk about the FDA getting angry with the CDC and then opening it up to everybody. But so it's April the 13th. First of all, I'm curious if you agree with the assumption that this is likely to come back in the fall, that we need to worry about September and October and November to see how that happens. But let's just presume that the assumptions that are being made right now, that the coronavirus will come back in full force in September or October. What do we do starting today, April the 13th, 2020, to prepare for the middle of September when we probably are going to see a second wave of this, so we can be in the best position possible to test, to trace, to treat, to isolate, to prepare in a way that's better than we did during the first wave?
Well, first of all, I think, Joe, one of the most important things you did was just state the obvious, that we have to be prepared for the future, and it's going to be worse. Think about this. We have about 20,000 deaths in the U.S. today from COVID-19. If you look at even the most conservative models over the course of the entire pandemic, of where at least 50% of U.S. citizens will be infected eventually, that actually comes out to about anywhere from 800,000 to 1.6 million deaths over the course of the entire pandemic. That's a long ways from 20,000. So it gives you a sense of what we still have to come. And so I think your point's a good one. The challenge we have right now, I can't get anyone to agree. We don't want to lock down, so therefore we have to come into some middle position. If we lock down like Wuhan, we can probably get a lot of people to the end of this till vaccines available, and then they can be vaccinated. That will ruin our society as we know it. We can't go willy-nilly and just say, okay, everybody, we're going back to where we were. Our hospitals will be overrun. We will have major challenges. So the question is, how do we do that? We have proposed, and we're coming out with a plan this very week, that will actually talk about how we have to let the younger age population in particular, the people who are at least at risk of having a serious outcome. It won't be universal. We do have serious illnesses in young people, but they are the people that can come back, get infected in many ways, and actually not require medical care or be seriously ill. Somehow we've got to thread the needle with this rope to get through there. And we got to have a national consensus. That's okay to do that. Some people will say you can't agree that anybody's going to get infected. Come on, everybody. Up to 50% of this country is going to get infected before this is over. So how are we going to do that, to do just what you just said? Get through this so we do the least amount of damage to our citizens from the disease, but also take into account what it does as an economy and society. That's the discussions we need to have right now, and those are the plans the federal government should be providing all 50 states. It shouldn't be done governor by governor by governor.
Well, as we talk about the fall, it's funny. It's interesting you're saying this and talking about younger Americans. Meek and I were just having a conversation offline with somebody about colleges. You go back in the fall. Do you
have kids in dorms?
Have kids in dorms,
sharing the same bathrooms?
Sharing the same bathrooms, where a very low percentage of them are going to have a negative impact from that. They could go to college. The problem is they can't come back home and pass it along to their parents or their grandparents or spread it in their own community. So that's the sort of thing that really does require an awful lot of attention and forethought. And as you said, requires a national policy to make a decision on, if colleges reopen in the fall. And if they do reopen in the fall, is there a limit to them coming back home?
Yeah, and I think this is where you can help a lot, and you have been. We understand as a country why the focus was on New York City, a metropolitan area, Chicago, Detroit, New Orleans, because they were on fire and they needed all the attention and help they could get. But as Sir Winston Churchill once said, this is not the end. This is not even the beginning of the end. Rather, this is the end of the beginning. We now need to realize we have a long road ahead of us. We've got to have these hard discussions. How are we going to get through this? And we got to have them in a way that doesn't accuse people of not caring about the cases of COVID, which are tragic, but also at the same time just touches on the reality that you just touched on. That's critical. And we're not having that discussion. That's where when I said about the testing, that's like a panacea. We'll just get a lot of testing and it'll be okay. Right. We're still going to have hard choices. So I think more kinds of conversations like we're having right now is what this country needs to hear so that we can do exactly what you're saying.
Yeah.
Let's do it.
I'm being told we have to go. I've got to ask one more question because I think it's critical that people understand this, and only you. I think people will respect you when you say this. Too many people are looking at this as a red state, blue state issue, a New York City versus Heartland issue. One of my biggest concerns, just from what I've heard from experts like you, has to do with rural health care. Woefully ill-equipped to handle this crisis. Older people are in rural areas. If people let down their guard in rural America, in heartland America, talk about the tragedy that will unfold then.
You hit a nail right on the head. I've said all along, red and blue will dissolve during the course of this pandemic into one color called COVID. And people will understand in the rural areas where one long-term care facility can have one outbreak, and suddenly the transmission now is in the community because we're all in seeing grandpa and grandma, mom and dad, and then it gets into the hospital, and you can bring down an entire rural area. We're seeing that right here in Minnesota. We're seeing it in Iowa. We're seeing it in those states where, in fact, these rural areas are going to be disproportionately hit. It won't come as quickly, and that's where people often think, well, this is a blue issue because it's New York, it's Chicago, it's Detroit. This virus will not miss one community. It will not miss one county. It won't miss one state. It's just going to be a matter of time, and that's why now we all have to come together. This is us versus the virus. This should not be a partisan issue about red versus blue. That would be a tragedy in of itself.
All right, let's have more of these conversations. Director of the Center for Infectious Disease Research and Policy, a professor at the medical school at the University of Minnesota, and author of several books on infectious diseases, Dr. Michael Osterholm.
Thank you so
very
much, Doctor. Thanks for checking out MSNBC on YouTube, and make sure you subscribe to stay up to date on the day's biggest stories. And you can click on any of the videos around us to watch more from Morning Joe and MSNBC. Thanks so much for watching.